bonjour, ça va. Ça va, c'est bien. هون عندي إياه هون وهون أصلا ما عندي مشكلة يعني هون وهون. Je les ai partout يعني. هيك ما بعذب حدا. بيبلش ما بعرف شو. عم بدأ. I can go. Okay, ما في مشكلة. Good morning, dear colleagues. It's my pleasure to introduce Dr. INT'L. He will talk about advancing patient safety in airway management and neuromuscular blockade. Dr. INT'L, he's an anesthesiologist at Rouen-Noranda Hospital in Quebec, Canada, head of the Department of Anesthesia and Pain Management in Rouen-Noranda, president of the Regional Medical Dentistry and Pharmaceutical Committee on Quality and Practice Assessment. Proud 2011 alumnus of the Faculty of Medicine at the University Saint-Joseph in Beirut, and he received training in anesthesia and critical care in Hôtel de France in Beirut and Hôpital Pitié-Salpêtrière in Paris, France. Dr. Christian, the floor is yours.
Good morning, everyone. I'm very happy and privileged to be talking to you today. I thank the organizing committee of the 29th Annual Congress of the Lebanese Society of Anesthesia for inviting me. My talk today will be about advancing patient safety in difficult airway management and neuromuscular monitoring and reversal. I have no conflict of interest for my presentation today. And to start, I would like to share with you what I think is the back theme of my presentation today, which is the passage of time. So consider the famous painting by Salvador Dali on the right called Persistence of Memory, where we see clocks so mellow and melting as if time is distorted and lengthened. In stark comparison on the left, a scientific paper showing the probability of the brain, of the human brain, surviving a cardiac arrest as a function of time spent in low flow circulation or no flow circulation. Really, we can assimilate this very short time, which does not need 5 to 10 minutes in most cases, to the cannot intubate, cannot oxygenate situation. And this small window of time haunted me when I first started residency in anesthesiology and critical care in Hôtel de France. My talk today is divided into two sections. The first one, I will share with you the 2022 American Society of Anesthesiologists Practice Guidelines for Management of the Difficult Airway, which was published earlier this year. And in the second part, we'll be talking about the neuromuscular blockade monitoring and reversal, which is really the recommendations of the task force, and hopefully will be published later this year. So the focus of the new guidelines is on management of the difficult airway encountered with masked ventilation, tracheal intubation, or supraglottic airway placement. Procedures now include diagnostic, elective, and emergency procedures, including the performance of invasive airway access. And the guidelines are intended for all ages, adult and pediatric patients for the first time, with either anticipated or unanticipated difficult airways, including but not limited to obstetric, intensive care, and critically ill patients. These guidelines are intended for use by anesthesiologists and all other individuals who help us perform anesthesia care or airway management. Also, these guidelines are intended to apply to all airway management and anesthetic care delivered in any inpatient or ambulatory settings. Now, in the past, the introduction of new airway devices into clinical practice accounted for the most significant changes in the ASA difficult airway practice guidelines. From 1993 to 2003, it was the introduction of the laryngeal mask airway in 5 different places in the algorithm, and from 2003 to 2013, it was the inclusion of the video laryngoscope either as an initial approach to the difficult airway or after failed intubation attempts. This is really not the case for the changes that have been incorporated into the most recently developed guidelines. Now, although similar in concept to prior versions of the ASA difficult airway guidelines, there are now two different algorithms, one for adult patients and one for pediatric patients. Here is the new version of the difficult airway algorithm for adult patients, which I will further break down into subsections. Additionally, there have been the creation of infographics for each of these algorithms. Here is the infographic for difficult airway management of the adult patient with the induction of anesthesia designed to serve as a cognitive aid that could be used for teaching purposes as well as in clinical practice during an encounter with a difficult airway. As you can see, it is color-coded to clearly delineate between the non-emergency and the emergency pathway. Now let's read down the actual difficult airway algorithm for adult patients. This first section is similar to the first part of the algorithm from previous versions, but as you can see here, it appears quite different. It now provides consideration for the development of a difficult airway management strategy, including considerations for awake airway management. This is such an important part of the algorithm actually, making the decision before attempting to secure the airway to choose between either an awake or a post-induction airway management strategy. Which strategy and techniques to use should really be made by the clinician, him or herself, managing the airway. This could be an entire lecture in and of itself, but basically the practitioner should ask themselves these 4 questions. Is there a suspected difficulty with direct laryngoscopy or with ventilation with either face mask or a subglottic airway? Is the patient at a significantly increased risk of aspiration or rapid desaturation? And any one factor alone may be clinically important enough to warrant an awake intubation, but other patient factors may require an alternative strategy. Please keep in mind that you should always evaluate the patient for the possible need to perform an emergency invasive airway procedure. Now let us apply this algorithm to this patient who is a 38-year-old woman at 34 weeks gestation, admitted to the emergency room with a right-sided tongue hemangioma that has bled, and she was experiencing difficulty breathing lying flat, as well as difficulty in swallowing, chewing, and speaking. There was concern that she would bleed again and she could easily succumb to airway obstruction during childbirth. On airway examination, although she could move her neck adequately and open her mouth well, as we can see in the pictures, she was a Malan-Petit 4. All you could see was her enlarged tongue. Now, when you review those 4 questions that I showed in a previous slide, all were positive. There is suspected difficulty with direct laryngoscopy with ventilation with either a face mask or a supraglottic airway, with ventilation with either face mask or supraglottic airway, and the patient was at significant increased risk of aspiration or for rapid desaturation. As such, now I hope you have already an idea what to do. The decision was made to secure the airway awake for the surgical excision of the hemangioma and eventual cesarean section. So she was positioned upright in order to maintain the patency of her airway as much as possible. And awake intubation techniques considered included flexible bronchoscopy, video laryngoscopy, direct laryngoscopy, combination techniques, just to name a few. But since there was such a high risk of a rebleed with any airway instrumentation, the decision was made to perform an awake tracheostomy. As you can see, they also prepped her abdomen in case there was a need for an emergency cesarean section. Now let's go further down the algorithm where the decision has been made to make an intubation attempt with either the patient awake or after induction of general anesthesia. Either there's going to be a success or failure with either decision you make. And in this particular case, there was success, and both mum and later the baby did very well. If the decision was made to intubate after induction of general anesthesia, you'll notice outlined in the red box is the recommendation to limit attempts and to consider calling for help, even at this point in the algorithm when there is failure upon initial attempt at laryngoscopy. Also in red is the recommendation to optimize oxygenation throughout the process of securing the airway, whether awake or after induction of general anesthesia. In fact, the task force recommends to properly position the patient, administer supplemental oxygen before initiating management of the difficult airway, and to continue to deliver supplemental oxygen whenever feasible throughout the process of difficult airway management, including extubation. Options include oxygen delivery by nasal cannula, high flow nasal oxygen technique, face mask, supraglottic airway, and even jet ventilation, to name a few. Now, as in the previous editions of the difficult airway algorithm, after a failed attempt, you will need to determine whether or not mask ventilation is adequate. If it is not, you have to consider or attempt placement of a supraglottic airway. The non-emergency pathway is on the left, where mask ventilation is adequate, and the emergency pathway is on the right, where either mask or supraglottic airway ventilation are inadequate. You can see by the arrows that I've color-coded green and red that you can go in either direction from one pathway to the other, according to the evolving clinical situation and adequacy of instruments that you use. I think that what is really important to point out here in the new algorithm is the emphasis on being aware of the passage of time and limiting the number of attempts of different devices and techniques during difficult airway management. Avoid loss of aversion and task fixation. On the non-emergency pathway, you can consider awakening the patient, and as mentioned previously, consider calling for help. And on the emergency pathway, you should actually call for help and simultaneously prepare for the performance of an invasive airway procedure. Communication is very important during difficult airway management. It is critical that the entire team understands the implications of declaration of a cannot intubate, cannot ventilate, or cannot oxygenate situation. Additional non-invasive interventions for difficult airway management now mentioned in the new guidelines include simple airway maneuvers, the use of combination techniques, and the use of extracorporeal membrane oxygenation. Now here is the new difficult algorithm for pediatric patients, which was developed in collaboration with the Society for Pediatric Anesthesia and the Pediatric Difficult Intubation Collaborative. In the interest of time, I'm not going to further break this down to go into details, but I would like to at least show you the infographic for this patient population. It is also color-coded to represent the non-emergency and emergency pathways, but they have added the color yellow to represent difficult or marginal oxygenation and ventilation. Rather than simply providing recommendations for contents of a portable storage unit, the guidelines now also include suggested items for all anesthetizing locations. The examples listed in this table represent basic minimum contents for anesthetizing locations. Here are all the items that were previously on the list for portable storage unit in black. Further expansion of that list are highlighted in blue. I think this is very important, as now these guidelines have a wider application in terms of settings in which they apply and the practitioners which may use them. The examples listed in this slide represent airway management equipments beyond what may be available in the anesthetizing location. Highlighted in blue are what is outside of the list in the previous slide about airway management items for anesthetizing locations, including the addition of a flexible intubate bronchoscope and jet ventilation equipment. It's important to keep in mind that the items listed here represent suggestions. As with the airway management items for anesthetizing locations, the contents of the portable storage unit should really be customized to meet the specific needs, preferences, and skills of the practitioner and the healthcare facility. Now, over the past decade, there have been an increasing recognition of the significant contribution of human factors to the safety and effectiveness of airway management. And this is a no-brainer. And interestingly, this time, the guidelines now take human factors into consideration, including environmental factors, team behaviors, and individual performance. This slide lists aspects of airway management that address how the practitioner may interact with patients, other clinicians, assistants, equipment, or the environment during which the process of difficult airway management is occurring. Practitioners may consider these factors before, during, and after the course of difficult airway management. Now, as in the previous versions of the ASA difficult airway guidelines, the task force regards the concept of an extubation strategy as a logical extension of an intubation strategy. So the new guidelines provide more robust recommendations for extubation of the difficult airway. And again, shown here in blue is what is new. Assess patient readiness for extubation. Assure that a skilled individual is present to assist with extubation when feasible. Select an appropriate and location for extubation when possible. Before attempting extubation, evaluate the risks and benefits of elective surgical tracheostomy. When feasible, use supplemental oxygen throughout the extubation process, as I've mentioned previously. Finally, appropriate follow-up and communication should be performed so that future caretakers will not unwittingly reproduce the same experience and risks. What's new in the recommendations for follow-up care includes the addition of the use of post-extubation steroids and or racemic epinephrine when appropriate. The other recommendations remain the same. Now, again, communication is so very important to the patient, the family, those who cared for and will care for the patient in the future. And the best way to do that is by documentation and to instruct the patient to register with an emergency notification service when available. In summary, I've tried to highlight some of the changes in the 2022 updates to the 2013 practice guidelines for management of the difficult airway. Successful airway management depends on preparedness, strategies, and skills. The vast majority of airway problems can be avoided with planning before airway management actually occurs. Attempts to secure the airway should be limited and optimized while paying attention to both time and oxygen saturation, and consider the use of a visual aid, a cognitive aid, or an algorithm when difficulty arises. There is no doubt that algorithms will continue to evolve with time. Lifelong education and training by us is really necessary, and further updates to difficult airway guidelines in the future will require successful assimilation into our own clinical practice to effect changes. I don't have a really long list of references. So the references, the two references are the practice guidelines for management of the difficult airway in 2013, which was an update to the 2003 version, and the current 2022 ASA practice guidelines for management of the difficult airway, both available on the ASA website. So now for the part of the monitoring and reversal of neuromuscular blockade. I'm aware that I still have just 3 minutes, and I will go directly to what the task force, which has been assembled in 2020, has recommended, and those recommendations will hopefully be published later this year. They have made an extensive literature review from 1990 to June 2022, and they have specific recommendations, and we'll start by enumerating them. Here they recommend against clinical assessment alone to avoid residual neuromuscular blockade. They recommend quantitative over qualitative neuromuscular monitoring to avoid residual neuromuscular blockade. They recommend confirming trainer 4 ratio at least 90% prior to extubation, the use of the adductor pollicis muscle for neuromuscular monitoring, and they specifically recommend against using facial muscles for neuromuscular monitoring, and the use of sugammadex over neostigmine at deep, moderate, and shallow depth of neuromuscular blockade to avoid the residual residual neuromuscular blockade when rocuronium or vecuronium are used. Neostigmine is still a reasonable alternative to Sugammadex for reversal of minimal neuromuscular blockade, so a TOF ratio between 40 and 90%, as long as we give it enough time to work. When neuromuscular blockade is induced by atracurium or cisatracurium, the task force suggests using neostigmine at minimal blockade at least 10 minutes prior to extubation to avoid residual neuromuscular blockade. Not pertaining to the adequacy of reversal for extubation readiness, there is no difference between Sugammadex and neostigmine's adverse effect profile to warrant the recommendation to use one drop over the other in that context. Now, why quantitative neuromuscular monitoring? Because we cannot subjectively identify subtle but still clinically significant fade. So what was truly dubbed the zone of blind paralysis, which is between 40 and 90% TOF ratio. And assessing ventilation alone is not meaningful because patients can have normal tidal volumes while the endotracheal tube is still in the trachea and will obstruct their upper airway because of the increased sensitivity of the upper airway muscles when extubated in case of really minimal or a shallow neuromuscular residual blockade. So in summary, residual paralysis remains an important postoperative complication, which is iatrogenic and possible to prevent, and the application of practice guidelines are an opportunity of quality care improvement in that context. Thank you.
I will introduce Dr. Jalbout, Dr. Jalbout. Vanda. Vanda, Dr. Jalbout will be with us. Dr. Jalbout. Any question, please? ما هو مش هيلعب مسألة ذاتية. أي إذا حدا عنده questions. Yes, please.
Okay, thank you, Doctor. My question is about induction of anesthesia and intubation without neuromuscular blockage for routine surgery, nose surgery or whatever.
You don't use muscle relaxant regularly?
Yes.
For regular intubation?
Yes.
Or in pediatric?
No, for regular. It's a good choice. What is the best strategy?
Okay, we'll see, Doctor. I want me to present بس عم بسأل سؤال هلا just ask a question. إذا في رد عليه دكتور. كمان disconnected. So we'll keep the question till the end. I will introduce. Okay. So I'm happy to introduce Dr. Gilbert Bejani. He will talk about how to increase efficiency in our daily work. Dr. Bejani holds his medical degree from the Free University of Brussels and is board certified in anesthesiology. He has several publications and presentations in the field of pharmacokinetic of intravenous drugs in anesthesia. He is head of anesthesiology department in the Basilique Clinique and chief operating officer for the operating theaters. He is legal expert for justice courts. He is medical director and executive director at the Basilique Clinic, Chirec Hospital Group, and has a degree in management of health institution. He followed an executive education on innovating health at INT'L and is member of the American College of Healthcare. He is Vice President of the Belgium Association of Physicians Syndicate, the largest physicians union in Belgium and President of its Brussels division. Dr. Bijani, the floor is yours, please.
For this large and nice presentation. So first of all, I'm happy to be with you. I apologize for not being in Lebanon because I was operated on my shoulder 3 days ago. And you will excuse my English since I've been living in Belgium since more than 30 years. So my presentation is like a practical one for your work, and it takes into account the lack of resources everywhere in every country and mainly in Lebanon. So let's not forget today is Anesthesiology Day and Happy Anesthesia Day for all of you. So let's begin with a situation, which is the situation everywhere in every country and in Belgium, in Belgium and in Lebanese also. We have an aging population worldwide since Second World War. We have a rising risk, which is the comorbidity added with age. We have a performance issue, which is the effectiveness of healthcare delivery systems everywhere. And of course, a rising cost with the cost of innovation and new techniques. And we can add to all that some other pitfalls and problems with the healthcare delivery systems, which is the hospital centricity, the overcapacity in hospital beds, and a lot of variation in care and waste. We will see that later on. We also have a problem in paying and buying these innovations. And last and not least, we have a shortage of caregivers, and we usually face this problem in Lebanon with the physicians and nurses leaving the country. So in summary, when you have this growing and aging population, you need to have a better primary care because it's cheaper. You need to customize care, and of course, you need to reduce variability in care. Variability in care is something that can be avoided in all, let's say, commonly done operations and hospitalizations. It's also a crisis of cost. So we move more and more towards integrated care, which is the connected care between GPs, first line, and hospitals. And we move towards a value-based delivery care, which I'll explain later, which is based on the economic model described by Porter from Harvard University. So the challenge is in the easiest way to realize something good is reducing waste and improving efficiency, like I'll try to show you. So the aging population goes with more disorders, and this is something really like normal, and you all know that. And you also, most of you know that this small part of the population, let's say this 14% of the population with the most morbid conditions, will cost more than half of the healthcare expenditures and money that is available. The OCDE says that in Europe, which could be worse, maybe elsewhere, we have up to 20% of really unnecessary care and more than 30% in some cases of waste in our care delivery. It's mainly redundant exams or not unnecessary exams. Why it is interesting for us? Because as anesthesiologists, we perform a lot of pre-op exams, and most of them are outside guidelines and are really not useful. You can add on top of that a healthcare system, which depends on the country, but in Belgium, with 3 regions, 9 ministers of health, you have a really complex, fragmented, and I have echo. You still hear me? Okay. So the solution for these problems is based on this book by Michael Porter, which defines value-based healthcare. So value is what you deliver to the patient as outcome, as experience, as less incidents at the lowest cost. So the lowest cost would be prevention. The lowest cost would be reducing care variation through standardization of care. And over country, it would be putting hospitals, into networks. The purpose of that is, of course, improving, let's say, everything. Accessibility, since you can keep smaller hospitals and facilities in proximity of patients in small neighborhoods. You can improve quality, of course, because you're going to measure it. You can reduce the pressure on caregivers because you're not doing everything everywhere. Like we say, it's the good care at the good place. When you do some efficiency, you can have some money in order to pay for innovation. And when you're measuring all of this, the money, the costs, the outcomes, you're more transparent, and this is something really useful. So on the big scale, the most effective cost reducing or the most effective value-based care action you could do is the restructuring your hospital in a network. This is what we call reallocating and resizing hospitals. So you would do the big operations in big hospitals, the university ones and the specialized ones, and you have to do easier stuff, easier operations in smaller hospitals. That's why we see in the States a lot of specialized daycare units. You can also reduce the variation in care delivery, and this is something we see in Europe through prospective bundle payment for some easy or like easy operations. And of course, reducing labor cost is the easiest but the stupidest thing to do, because this is not something that is sustainable on the long term. So in Belgium, we have more than 100 hospitals. Belgium is only 3 times the surface of Lebanon, but we're moving to 25 networks, so 25 big hospital networks. And now I'm going to share our experience in our hospital group in the small clinic where I work, which is a day case clinic. We only do day case surgery. We believe, through what I've already explained, that we can deliver really value-based care, reconciling the cost of the care we are giving and reducing it to its maximum, and still delivering the best quality to patients. Achieve that, we would achieve that through process analysis, lean management, reducing redundancies, reducing errors, reducing waste, and trying to focus on patient experience. And I have a few recipes that I can share with you, and I hope it will be useful for your everyday work when you're facing reduction in resources and in a shortage in caregivers. So this is the biggest hospital of our hospital group in Brussels, more than 1,000 beds in total. And the clinic where I was really, really old. So how did we manage to bring the results that I'll show you at the end? The building is old, it's from the 60s, but I mean, who cares? This is not the main, I mean, I've seen this in all the value-based equations I've shown. So building age is not a problem. It's small, but still we have 5 operating rooms. And what we did is, when we closed all our in-hospital beds, is that we adapted the architecture to day case surgery. I'll show you how. we made smaller rooms without a shower, for instance, and with less space because patients won't stay long. So we have a lot of rooms compared to our operating room. We have more than almost 50 rooms for 5 operating rooms. And we increased a lot of PICU beds compared to inpatient hospitals. So we have like 15 or 20 PICU beds, which allows a huge turnover. This is one of the levels in our, we have 2 buildings. This is the first building. So as you can see, we have 2 operating rooms here, and we had 2 beds for recovery, which we increased to 8. And in the other building, we have 2 operating rooms, and we had like few beds for recovery, and we increased them to 8 also. And all the other levels are now consultations and mainly beds for patients. So the timeline and what happened in our clinic is that in 2015, they decided to close all inpatient beds. We had like 100 beds, and they transferred them in a bigger hospital, which is the network philosophy I just explained. It's reallocating the activity. And we decided to keep the building working and open to do day case surgery. We had a huge and big analysis of all kinds of patients and surgery we were doing. We also analyzed the workflow and what happens when patients arrive in the morning. For instance, we have like 50 patients or 60 every day. If they all arrive at 8 o'clock, it would be a huge problem because we really have not more than 10 secretaries on every desk. I mean, for all desks, and we have normally two persons at the admission. So we need to have every one of them taking care of 25 patients when we admit 50. So we did all this analysis, and let's go further to see the results. So when we speak about Lean and Six Sigma, I mean, you don't have to go into detail. It's mainly reducing variation, reducing bottlenecks, reducing errors in order to have a better flow, which costs less, faster one, and of course, with the patient satisfaction. So our patient flow in hospital is based on, let's say, 3 moments, 3 contacts. When the surgeon sees the patient, he decides he's going to operate. So this is first the first important moment. Then we organize everything in order to have the patient only once visiting the hospital, or since we have the video consultation, they are not visiting anymore. We call them before, and then they have to come the day of surgery. What happens in the meanwhile is that when the surgeon sees the patient, he has a simple planning. It's a web-based, it's an Excel spreadsheet I did like 7 years ago, and it works fine because they can access it from anywhere. Once they fill the form for the operating request, it generates like an email and now a notification in the admissions desk and the secretaries at the operating theater. Then the patient will call, or he will have a call. If he has a request for video consultation, he can have it. Then we will go through this process describing here, and the last day we will do a final check before the operation. So he will be called, and we will tell him to come 2 hours before the operation. So the first one arrives at 7 because we open at 7, operation at 8. Then the second one will arrive, let's say 7:30, operation at 8. Then he arrives at 8 for 9, for 10, and then it goes 2 hours. I mean, at the beginning it's 1 hour, then it's 2 hours. In any case of problem, no one will cancel the case without calling the anesthesiologist. So when he comes the day of the operation, or sorry, the day to the pre-op exams, he will visit the anesthesiologist. We don't do the battery of lab exams on a regular basis. It's based on the exam by the physician, the anesthesiologist. Then the day of surgery, we have a lot of checklists. We have a lot of procedures in order to avoid any error. I won't go into detail, but this is what we do. So this is just an example of the operating planning. We have it in detail in the upper part inside the hospital, but from outside the hospital, and you see this is from 2019, it's really available. So surgeons can see easily when an operating room is empty and they need to occupy it. So the resources, besides the building, we have some pharmacy with the group. We organized a lot of our material, and we have a follow-up of all our inventory. This is really important. We invested a lot in equipment, not the building, not the walls, the equipment. We have really the latest, maybe the most expensive equipment we have for anesthesiologists, for instance, a glide scope in every operating room. Equipment is important because surgeons feel, anesthesiologists also, and physicians like to work with good material, and when the organization is adequate. The building again is not important. The people, and this is maybe the most important point, is bringing everyone to accept this change. So when we close in hospital beds, a lot of nurses left the clinic. The ones who stayed really believed in the project we were doing. So we open at 8, we close at 8, there's no one at night. We have an alarm, we don't even have a guard. And it was really important to work with the people as a team to communicate. And there is 2 points I would like to show you. It is the shifts in the time shifts for nurses in the operating theater. This is something we did, which was really like first time in Belgium. And we also modified the opening hours for our day case surgery, day case theater, because usually day case units work from 8 to 4 p.m. in Belgium. And they have this 8-hour regular shift for nurses, which was adequate for inpatient hospitals where you have to work through 24 hours. And this is something that really was a major point in the progression of our activity. When you work on an 8-hour opening time of your operating theater, you don't work every time till the end of it. Why? Because if you go further than 4 o'clock, you will have to keep the patients in hospital, and that's something you want to avoid. You have a variation in these first two sets of bars. You have a variation of the finishing time of an operation. When you begin at 8, you will have maybe an operating room which will finish at 2 or maybe 3. Really few of them will finish at 4. And when you're not sure it's gonna finish before 4 o'clock, the normal tendency is to stop the operating room, and you will tell the surgeon you can't do this anymore. Whilst when you open 10 hours like we did, you can accept more interventions in the afternoon. So it seems like you're just adding 2 hours, but in fact, you're gaining more than a third of number of operations. Why? Because you're not afraid of beginning operations at 3 o'clock. And this is something really important. The other thing we did is the time shifts for nurses. So our clinic opens 12 hours. This is a law in Belgium. Then our operating theater opens 10 hours. We could maybe do it for 12, but we needed some time before and some time after for discharging patients. And in a usual 8-hour shift for nurses, you will have a nurse for one operating room that will come in the morning. Since she cannot stay till the end, if you go a little bit after 4 o'clock, or really if you need to stay with the patient for its discharge, you will have a huge overlap. So you're losing a lot of nursing time with, for not needed jobs. What can you do at this time in the middle of the day? Eating, or maybe not even preparing for next day because the operating theater is still working. So we proposed a 6-hour shift for our nurses. And when you do 5 days, 6 hour, of course, you don't have your 40 hours package, which is the usual working time per week in Belgium. So we are mixed 6-hour shifts with 11-hour shifts. And when you see this, sorry, you will have one nurse for in the morning, but the same nurse, when she will do 3 days, 6 hour, she will do 1 day, 11 hour. So some other days, they will have 2 nurses in the same operating room. And this is really helpful for orthopedic surgery with a huge turnover, for ophthalmology and cataract surgery, where when the turnover is more than 15 or 20 patients per operating room per day, you need a nurse. So with less nurses, you have the impression that we have more nurses in the operating room. And these are our results with all the processes and procedures we wrote. We have 100% of all patients coming to pre-op exams with the anesthesia, except of course cataract surgery. We have the hospitalization rate of, let's say a failure after day case surgery, less than 1/1,000. So over a year, we have 8,000 operations. Maybe we have 7 or 8 patients that needs to be hospitalized. Usually, since we have good selection, a pre-op selection, usually it's not even for pain. It's sometimes like they feel a lot dizzy, or some of them really request that, even so they didn't ask for it before. We operate a lot of ASA3 patients. The cancellation rate is less than 1/1,000, of course, because we do this check when the patient comes to the pre-op exams, and we do the check 48 hours before, and we call all of them the day before. So it's almost impossible for a patient not to be aware that he's operating the next day. We do a lot of other exams, and when we do these, we do them the same day of the visit at the anesthesiologist. We have agreement with cardiologist, pneumologist, also radiology, so we can have all the exam on the same day. There is less, conflicts in the operating room, since we brought nurses, surgeons, and anesthesiologists in a daily based discussion, a weekly based meeting, and the monthly based also meeting for all the group coordinating the work of the operating room. And in 7 years, we almost doubled our day case surgery volume from 4,000 to more than 8,500. We didn't even add a lot of nurses. We began with, let's say, 35 nurses. Now we have like 40 nurses for more than 140 doctors. This is kind of strange equation. It's inverse, in fact. Normally you have much more nurses. We have a lot of doctors who come to operate like a few hours and then they leave. Of course, we are sustainable since we are earning money, and that's why we kept our place in our huge group. We have, as I said, 5 operating rooms, and now we put the endoscopy outside the operating rooms and the pain clinic also outside in order to gain some place in the operating rooms. So these are the results, and I'm almost finished. So at the beginning, the plan was this, focusing on value-based healthcare with not outpatient, but the day case surgery plan. It is the only standalone day case surgery unit in Belgium. It is in this clinic, the International Ambulatory Association of Surgery was began in 1992. It was in our clinic, and now it has its congress last year. It was in Bruges in Belgium, but the reality is really like you see in the lower part of the slide. It is a lot of meetings, a lot of pitfalls, But I mean, you should always keep hope and keep focusing on your perspective and the objective. And this is something you have to do every day. And when you have an objective and when you really succeed in bringing the whole team, the whole nurses, the whole anesthesiologists, and the surgeons with you in this kind of project, definitely it works. Thank you. And I hope I respected the time that was allowed for me.
They can connect.
Thank you. Good morning, everyone. It's a pleasure joining you. I'm presenting Dr. Lahoud, she's a USG Hôtel-Dieu alumni. She finished her training in Bicêtre University Medical Center in France in 2015. After graduating, she worked at the Seydet Zarta University Medical Center for 2 years, being at the head of anesthesia department. In 2016, Dr. Lahoud had a postgrad training in hypnosis in anesthesia at Paris Sud University and started practicing hypnosis as much as possible on her day-to-day practice in Lebanon. She has been in Switzerland since 2017 as an attending anesthesia at University Medical Center of Geneva, member of hypnosis department, and coach of hypnosis in the anesthesia unit. Marie-Josée, à toi, cher ami.
Okay. Okay. Okay, any questions to Dr. Gilbert?
Dr. Gilbert, I enjoyed your presentation and your amazing results. Well, my question to you is that I'm always having a lot of problem with my surgeon related to the time they mentioned the surgery will take and the time they spend during the surgery. I know you're not doing major cases, but even in minor cases, things happen. Surgeon might be late coming, and working with 140, I think you mentioned surgeon, how you're dealing, coordinating, and making them cooperate with you as much as this. Thank you.
This was a choice we did. This was an important one, is choosing the program for operating theater management. So we have a standardized time. It's a mean time per surgeon, per surgery. And when they just fill in the paper to register for an operation, it's a time that was allowed, it's a time that is given for this surgeon for this type of operation. So he cannot change it. And it's a moving average over the last 20 operations he has done. So if he improves, it will be smaller. And if he tries to cheat, let's say he will put another title for let's say an abdominoplasty, and he will say it's a lipoaspiration, let's say. So he will be affecting the regular time of his lipoaspiration. So if he cheats, he will be paying the price of his cheating. So we don't really focus on what they are writing, of course, because we need to prepare the material. But when they try to cheat, we see it, and we just make a friendly remark, and this is managed by the operating time that is given to each of them. Does that answer the question?
Gilbert, bonjour, je suis Patrick Narchi, on s'est vu en France plusieurs fois.
On se connaît bien, oui.
Oui, j'imagine qu'avec votre système, en Belgique, vous devez faire du fast-tracking en ambulatoire.
Exact.
Sûrement. Quel est le maximum, le nombre de cas maximal que vous pouvez faire sur un seul lit dans une journée pour la chirurgie courte, par exemple, chirurgie de la main, ou sur un seul lit, vous faites fonctionner combien de cas au maximum?
Pour la cataracte, on en fait 20. Pour les arthroscopies, par exemple, d'épaule et de genoux, on en fait 8. Pour la chirurgie vasculaire, varices et tout ça, on en fait 8. En stomatologie, on en fait, chez les enfants, enfin les extractions dents de sagesse, etc., on en fait 10 ou 12 par lit par jour. Alors, on fait maintenant beaucoup de cas de plus en plus lourds. On fait des abdominoplasties circulaires, on fait des ostéotomies, donc, voire même parfois mandibule inférieure. On les fait au matin, on fait des ligamentoplasties. Le problème en Belgique, c'est, je ne l'ai pas mentionné, mais on a un sérieux retard en chirurgie de jour. On était en avance dans les années 90. Depuis, on est devancé par tous les pays. Souvent, je présente la France comme plutôt un exemple. On est à 50% de chirurgie de jour quand les autres pays sont à 70-80. Mais du coup, dans ma clinique, les chirurgiens préfèrent sacrifier l'hospitalisation pour garder le confort d'une liberté que je leur ai donnée. Ça veut dire qu'ils ne vont pas aller sur un site hospitalier pour une opération plus ou moins lourde, ils vont quand même essayer de la faire. Donc, on a commencé à faire quelques hystérectomies, quelques cholécystectomies. Voilà.
Yes, I have a question.
Please.
I'm sorry I couldn't present you, but they did an excellent job instead of me. I had the problem with the connection. So are you using the recovery room for any purpose, let's say for minor procedures or for patients who doesn't wake up regularly? And the second question, people don't work for nothing, for no money. Do you pay money to thank you.
I didn't hear the last question. There was small cut in what you're saying about the money. So first of all, about recovery room, yeah, we use it as a recovery room. I mean, anesthesiologists are really aware that we are doing day case, so they avoid a lot of useless drug like droperidol and stuff like that. We use mainly remifentanil with blocks for orthopedic surgery, remifentanil with propofol and some sevoflurane. We really don't use a lot of clonidine and other all drugs that could delay the discharge of patient. We are avoiding them. I mean, it's classical. But we have seen in Belgium, I mean, I was really happy to see that the American Society of the SAMBA and the American Society for Ambulatory Surgery, that they are also going towards bigger operations with patients much more than close to ASA 3 than ASA 2, and discharge is not. I mean, is surprisingly not really affected by this type of operations. As for the money, in fact, in our hospital, nurses earn less than the nurses in the group. Why? Because they lost the working hours at night and they had like a bonus of 15%. So they earn less. So what are we proposing? We are proposing a little bit of quality of life. They don't work on weekends. They don't work at night. And I really insist on the respect we should give them. So when a surgeon is a little bit upset or whatever he says, which is not really appropriate, I mean, everyone can call me at any time. I'm really available. I will tell him. So please, I mean, try respect of the personnel and the nurses you're working with is fundamental, especially when you know that they are earning less. So it's not all about the money. It's about the conditions you're creating for the working environment.
Thank you.
I do have a question.
Yep.
Yes, thank you, Dr. Gilbert, for the nice presentation. It's really very impressive to see such progression in your day case surgeries, taking into account the different types of surgeries and most importantly, the large number of surgeons. My question is simple and direct. How often do you have conflicts in your workplace? I mean, by conflicts, those disagreements that happen between you as anesthesiologists and surgeons and, of course, the nurses. Thank you.
Difficult question because we have what I call incidents, minor incidents. We really deal with them every week. And since 7 years, every week, we have like more than 400 reports of our meetings. So every week there is something. It's never a huge problem. So it's never a big conflict. Why? Because the rules are simple and everyone understood them. We have the rules of operating theater. It's more than 200 pages. So surgeons have to sign it. So everyone knows the rules. So when you don't, let's say, when you don't use your reservation time, 5 days before the operation, 5 days before, your reservation would be, you will lose it and it will go for someone else, which means you can also take all availabilities from other surgeons 5 days before their surgery if it's not occupied. So one rule goes for someone and it goes, I mean, in one way for you and in the other way for others and vice versa. So what you accepted that is a constraint for you would be useful in some other situations. And since everyone knows the rules, I just have to remind them the rule. Let's say he would forget on sending the registration paper and we check it the day before. So the day before, after noon, you cannot add any more patients, which is really, really flexible. You can add till the day before at noon. But when they call in the afternoon, I would say no, and that is no. And I won't discuss it anymore. It's easier maybe for me because I am chief anesthesiologist and also director of the clinic. So you have a kind of authority, and this is something important. I mean, even if you're not what we call the CXOs, you need, when you work in an operating theater, your supervisor, your director should be always supporting the chief of the operating room. If you are once not respected, when you have a conflict with any surgeon or any person, or even anesthesiologist, you lose all your credit. So chief of the operating theater should have a kind of authority that is supported by hospital management.
So there's a kind of hierarchy, and you are on top of that hierarchy. That's
yes.
What you say is what it goes.
Yeah, it helps. But even if it wasn't myself, because before in 2003 we had another director. He was a pharmacist, but we had a really good understanding and agreement. And the agreement was he was always supporting me, always, and that helped a lot in writing the procedures. But all procedures are sent to everyone. We say everyone can challenge any rule if he can put it on paper with arguments. If it is if it's an acceptable proposal, we will take it into account. Everyone can challenge any rule any day, but once the rules are written, everyone has to respect them.
Thank you.
Hello, Dr. Marie-Josée Lahoud. You can go, I think.
Hello, everyone. I'm so honored to be with you today, and so sorry for this technical bug. Thank you, Mustafa, for the presentation, dear friend and colleague. I'll be talking for the next 20 minutes about hypnosis in anesthesia and pointing the importance of this technique in different departments, in different stages of the patient's pathway. You should just give me the command when. Okay.
You can talk, I think.
I can't move. I can't control.
I think we are connected. You can talk. She's connected, but she doesn't know that she is. Okay. It's mute. We cannot hear you.
Do you hear me now? Everything's fine.
Now it's better. Now it's better.
Now you're hearing me?
Yes.
Okay, perfect. I hope it's worth waiting for my presentation. I will start by talking about the definition of hypnosis with some practical examples. I'll talk about hypnosis in different stages in anesthesia. I will give you some literature review, briefly talk about pediatric population, conversational hypnosis, and I will conclude with our program in Geneva in Hôpitaux Universitaires de Genève. Let's start by defining what is hypnosis and saying what is not hypnosis. In the noun hypnosis, there is the Greek suffix hypnos, which means sleep. But hypnosis is definitely not a state of sleepness. It's neither a show, it's not manipulation, and it's not magic. Sorry, the slides are a bit slow to come. The best definition for hypnosis, for me, I got disconnected. I don't know if you're seeing the screen correctly.
Yes, go ahead.
Okay. The best definition of hypnosis for me is fighting well, I don't know, but it's the definition given by the American Psychological Society in 2014, which states that hypnosis is a state of consciousness involving focused attention and reduced peripheral awareness. And at this moment, the patient has enhanced capacity for response to suggestion. So we dissipate the patient's attention to help him or her cope better with pain, to be less anxious, and feel better. And hypnosis is scientifically proven, and it's mainly the team of Marie-Elisabeth Feymonville in Belgium, who did a lot of neuroimaging, which showed that in chronic and acute pain, the hypnosis alters the pain neuromatrix activity and raises the threshold of awareness in general anesthesia. So there's a decreased activity in the cortical and subcortical areas in thalamus and zen, and there's associated enhanced activity in the anterior cingulate cortex. And the anterior cingulate cortex is the center which regulates the interaction between cognition, perception, and emotion in the management of painful stimulus. So in practical, how do we do hypnosis session? We should start by establishing the relationship with the patient, asking what does he like, what does he do for a living, what's his lifestyle, his or her lifestyle. And then we start the induction, the session. It's the time when we turn off the external network. It's like in yoga or meditation, where we invite the patient to focus on breathing, on body scanning, using the 5 senses to make him disconnect for his or her environment. And then the patient is entranced. So this is a period where we activate his or her creativity, the imagination, and do positive suggestions. And there's where we do the therapeutic work. And at the end of the session, we invite the patient to return to his or her ordinary state of consciousness. To give you some practical examples, our main concerns as anesthesiologists are pain and anxiety. For pain, one technique is to make the patient imagine a glove. Imagine the texture of the glove, the color, the form. And when the patient is just focusing on his or her hand and thinking of this glove, he will feel a bit, his hands starting to get numb. And then we invite him to go pat or touch the painful zone. And in 95% of the cases, at the end of the hypnosis session, the patient will say that the pain really disappeared. We can use also other examples like soft cotton or cold to go encircle the painful zone, or to paint with colorful colors. For anxiety, we could just propose to the patient to imagine his or her safe place, a place where he's just fine and relaxed, and to invite him to project himself or herself in the after surgery, in the where everything is over, everything is fine, surgery is done. And to make it brief, hypnosis, it consists in using all the negativity around the patient, to use our imagination to turn these stimuli, like the sound of the monitor, the lights of the OR, to turn them into positive suggestions and positive ideas to make the patient feel better. In anesthesia, we can use hypnosis intraoperatively, pre or post-operative. Let's start by talking in the intra-op phase, which is called, and this is what we call surgery under hypnosis. Let's face it, it's not surgery under hypnosis alone. The surgeon should do local anesthetic And we must add, in the majority of times, some little sedation with dexmedetomidine, mainly used for superficial surgeries like thyroidectomy, some plastic surgeries, lipoma excisions, dental care, in colonoscopy. And this is very helpful in and has a major advantage in patients with high disease to avoid to do general anesthesia. It's not the subject of my talk today, but you should know that when we have this kind of technique of anesthesia, we should see the patient for 2 to 3 sessions before the surgery to prepare him to be ready to cooperate with the surgery. Another way to use hypnosis is to stay with the conventional anesthesia, or either GA or local regional. And for anxious patients or patients where we don't want to do premedication and to avoid the secondary effect of benzodiazepine, or when we have patients that has phobia, needle phobias, we can propose sessions before the surgery, either as short session to 5 to 15 minutes before the GA, or while doing the spinal or doing the local regional anesthesia, or prepare him with 1 to 3 sessions for the surgery. And these short sessions will generate an overall state of well-being in dealing with the GA. The patient will have better awakening and better personal experience with the surgery and OR. In post-operative phase, we can also use hypnosis mainly by teaching the patient to do self-hypnosis. And what we noticed that these patients, when they know how to do self-hypnosis, they are more relaxed. And even though the studies are not so strong, the design is not so strong, but some studies, the literature has shown better sleep and less nausea when the patient knows how to do hypnosis. It's a good technique to use when you have problems with memorization or very bad previous experience with anesthesia. And hypnosis has become more and more a tool in dealing with chronic pain. And there's training programs to add hypnosis to treat chronic pain. In the last 5 years, there have been a lot of studies designed to prove the effectiveness and plausibility of hypnosis in anesthesia, mainly in the gynecological field and breast cancer surgeries. Here's one study published by the French team in 2018. It's a prospective randomized trial with 150 women randomized in 2 groups. The group hypnosis had just a 15-minute hypnosis session before GA, and it was statistically different many outcomes, with lower use of intra-opioids and hypnotics, with lower stay in the PACU units, and better post-operative outcome with less fatigue and anxiety on the evening of the surgery. Here's another study with another design in ENT with septorhinoplasty groups, hypnosis versus no hypnosis. In this study, they did 3 sessions at 3 days before surgery, 1 day before surgery, and on the day of the surgery. And it was also statistically different, with less remifentanil used intraoperatively and better pain score, here in blue, with the hypnosis group feeling less pain on post-operative phase. And there's another publication with orthopedic patients with arthroscopy. In these studies, they teach the patient to do self-hypnosis, and the patients did 2 sessions a day for 2 days before the surgery till 1 week after the surgery, and there were also better outcomes with less pain. There's a meta-analysis in gynecology in breast cancer surgery, including 8 studies, which it showed also a reduced the preoperative anxiety and reduced postoperative pain, and also a Cochrane review of 2016 with a trend towards pain reduction, length of stay reduction. We know that hypnosis works well in adults, but it also works in pediatric population. Starting 4 years old, we can use it with children. It's more distraction and a playful way, and it will help the patient to cope better with the treatments and the exams. We can use it for dental care, for gastroscopy to avoid GA, dermatological procedures. Here's an example of a little girl of 8-year-old who had dental care with hypnosis, and she was really creative, and she imagined balloons. She imagined that she put ice cream on her mouth and she didn't feel anything during the procedure. And I will briefly talk about another type of hypnosis, which is called the conversational hypnosis. In this case, it's an informal form of hypnosis. We don't need to take the patient's consent. He doesn't know that we are practicing hypnosis. It's just how we talk, the tone of our voice, how we touch the patient, how we stand when talking with the patient, and giving always positive suggestions. And automatically the patient is relaxed and has a better experience and overall. To give you an example, when we are talking to the patient or putting the IV line, we should not use negation because the patient will not hear the negation. So we don't tell him, don't be afraid, don't be afraid, it will not be painful. He will hear afraid, painful. So it's better to go and tell him everything's gonna be fine, or you'll be comfortable. Are you comfortable like this? Think certain ideas, positive way to speak with the patients. In Geneva, we have a program, and we are forming everyone that wants to healthcare staff, nurses, doctors in any field, to know the basics of hypnosis. It's a session of 5 days where we mainly teach conversational hypnosis to ameliorate the well-being of the patients when they are hospitalized. And in anesthesia, starting 2018, in the anesthesia department, we are around 35 to 40 nurses and doctors formed in hypnosis. And 3 of us, 2 other doctors and myself, we have the hypnosis clinic. It's 1 day a week. We have a consultation, 1 hour with the patient, where we prepare the patients for the surgeries, help them with pain management, help them with smoke cessations before the surgery, or any other indication for hypnosis in the perioperative state. We have a program for major surgeries, total knee prosthesis, and especially major abdominal surgeries, where we propose to the patients 2 to 3 sessions before the surgery to prepare them to cope with everything, to be prepared for the rehabilitation period. And any anesthesiologist in the pre-anesthesia consultation, if he sees the necessity when there's anxious patient or patient with needle phobia, or at the patient's request, with a click in the pre-anesthesia consult form, he will request a hypnosis session, and this will schedule a session with us. And we have a mail where surgeon and patient themselves can ask to have these sessions in preparation to the surgery. In conclusion, I'd like to say that hypnosis is a technique where we use no drugs, there's no secondary effects, and it's really effective in the 3 phases of surgery. It will reduce the stress in the pre-surgical phase. It will reduce the administration of anesthetic drugs intraoperatively and improve the management of post-operative pain and the quality of life after the surgery. Thank you for listening. Once again, sorry for all the technical problems, and I'm all ears for your questions.
Any question?
Well, personally, I enjoyed it a lot since we've been using it kind of unofficially. But my question to you, do administration approve it, and do insurances pay your the cost of those settings, or it's a kind of patient request and you charge them by patient?
I'm luckily working in Geneva. It's covered by the insurance. So when they come, it's all covered. It's like $250 a session, but it's all covered.
This is really nice. We don't have this opportunity here. Huh? We don't have it here. Thank you.
I know this, but I think doing the sessions is, we have the chance to do this, to do 1 hour with the patient in a clinic, but hypnosis has a lot of indication in the OR. We don't need to let the patient pay more. It will help him feel better, cope better with the surgery. And really, it's by just the way we talk to the patients and just coming, and when we do the tell the patient, I suggest you to think of a nice place, maybe go to a vacation, go by the sea, and we can see the patient breathing slowly, and the heart rate is turned, and he will help us better with the anesthesia preparation. I know it's the best thing is to have all this system, to have a hypnosis session, but it's also helpful in other ways. While doing an epidural for a woman in labor, when she's moving all around and painful, we can just invite her to think about her baby, to imagine her baby in her hands, and she will cooperate. She will breathe better, sit better, and we'll do the anesthesia more easily and with less risk.
Definitely is with big benefit for the patient and for the doctors too, practicing.
True. And for the OR team, because when we are talking to the patient calmly and relaxing and thinking about the sea and the vacation, everyone is calm in the room, and they are doing less noises, and it's really helpful for and benefit for everyone.
Thank you. Any more questions? Okay. Thank you, doctors, for the speakers for your really nice lecture, and hope to see you in Lebanon.